Welcome to the Pathology Report. My name is Leo, and I'm hosting a podcast today on precision medicine. I'm joined with Associate Professor Vanessa Tyrrell. Good morning, Vanessa.
Good morning, Leo.
Can you tell me a little bit about what precision medicine is?
I can. Precision medicine can be a lot of things, but I guess in a nutshell, what we're really looking to do is find far better, more personalised, individualised options and treatment and ways of diagnosing and prognosing patients. So if you imagine that medicine 40 years ago, you might say, well, somebody has leukemia, but it was just leukemia, whereas these days there are multiple different types of leukemia that you can get. So the idea of precision medicine is that we use all of the tests, whether it be genomic or immunology or biochemical, to really try and understand more about the disease or the disorder that somebody has so that we can be more personalised in the way that we treat them.
That's really interesting to hear. And so what is your role? And I understand that you direct a program around this. Would you be able to explain a little bit about what sort of program that you help run?
Sure. So I'm the director of the Zero Childhood Cancer National Precision Medicine Program. And my background is actually genetics. I started out a very long time ago. So I have an amazing team of people now, a very large team of people now that do most of the really fancy work.
Oh.
And the Zero Childhood Cancer National Precision Medicine Program is a program for all children with cancer. And we actually started out in 2015, 10 years ago.
Yeah.
And what we were trying to do at the time was really try and understand whether we could actually use genomics and biology and various other aspects like immunology to understand a child's cancer better so that we could treat more effectively. And this program is based on genomics in the main, as well as multiple different research projects that we have coming out of that, including preclinical in vitro drug screening and trying to establish laboratory models of a child's cancer in mice to then say, well, what's the most likely effective treatment that we could try in these laboratory models to see how the tumours respond. The genomics itself, we perform whole genome sequencing, whole transcriptome sequencing and methylation profiling on the child's tumour. And we also perform whole genome sequencing on the germline of the child, so the DNA that they're born with, to understand if there was any genetic variant that they were born with that has predisposed them with developing cancer so early. And we were doing that for the high-risk children, so less than 30% chance of survival, very aggressive. They could be relapsed or progressing, and there are limited or no treatment options. That's where we started.
Yeah.
And we rolled that out nationally in 2017. And then in 2020, we were lucky enough to secure research funding from the Commonwealth Government. It's a joint initiative between the Commonwealth Government and the Minderoo Foundation to actually expand the program to be available to every child with cancer in Australia.
That's very impressive. So from what I can hear, you're integrating, you've got clinical and laboratory data, and you've got research and animal data, and you're putting them all together. And am I correct that this is being done on all sorts of different types of cancers, common ones and as well as rare ones, to try and deliver the best outcome that you can for the individuals?
That's right. That's right. And so the integration of genomics, and we call it multi-omics. So the integration of your, the information in your DNA, in your RNA, and in, whether something's switched on or off through the epigenetics, that is all combined, and then the biology is studied as well. And we also have a joint initiative with Peter MacCallum Cancer Centre in Melbourne, which is a paediatric immuno-oncology program, because they have expertise in immunology, we have expertise in children, so we join forces to work together. And we have a lot of research programs like that.
Oh, so it's also a very big multidisciplinary team then that needs to get this.
It's a very big team. And because it's national, we have the program and the trial available at all 9 paediatric oncology centres around Australia. And we have a lot of research collaborations as well. So it's a truly national effort.
And is there one particular cancer that you have been very strong in or been very well recognised for the work that you've done?
The Children's Cancer Institute, which is where the Zero program is based in terms of the laboratory teams, they have got a history in neuroblastoma expertise. But through Zero, we have expanded all of the, we've expanded our knowledge across all cancer types. In the aggressive cancers in children, or rare and undiagnosed, but many of the aggressive cancers, about 40% of them have been brain tumours.
Oh, right.
So we've been working to expand our knowledge of these brain tumours so that we can better understand what the more likely effective treatments might be, and also looking for novel treatment options for children, particularly where there are none.
That is very interesting. And I guess, particularly when we're looking at slightly rarer cancers, is there particular obstacles like finding enough patients, trying to get enough information or data? And have you encountered any sort of obstacles around that?
That's a really good question. So childhood cancer is a rare disease in itself. There are about 1,000 children a year in Australia who are diagnosed with cancer. And so there are also around about 150 different cancer types within the 1,000 children a year. So it's very rare. And so in a sense, we face some of the same challenges that the rare diseases community faces, which is a global challenge. And it means that we need to work globally to find the children who have these particular cancers, to understand them better. I think the whole genome and the whole transcriptome is helping a lot, because we can learn a lot more and we can find a lot more than we would otherwise.
So it does make sense to have a national program in that case. Then that way you can capture all the patients within Australia.
That's right. And in fact, last year I was very pleased that we were able to open Zero in New Zealand, in Christchurch and Auckland, for very complex or high-risk cancers. And hopefully in the future we'll be able to expand in New Zealand, and potentially also other countries as well will be able to benefit.
Oh, that is very interesting. I didn't know it's in New Zealand as well.
It is.
Then do you have sort of similar collaborators who have similar setups that you can work with across an international space?
There are some similar programs.
Yeah.
Zero is a world first in making this program and precision medicine available to every child with cancer. Most of our collaborators focus on the aggressive high-risk cancers with that sort of less than 30% or less than 50% chance of survival. But we have strong collaborations with the German equivalent in Heidelberg. We have a strong collaboration with Terry Fox Profile, which is the Zero equivalent in Canada, across 3 centres in Canada itself. There are also similar programs in the UK and in other countries in Europe, in the Netherlands, in France, for example. A little bit more challenging in the US because of the way that healthcare is set up in the US, but there's a very big initiative called the Molecular Characterization Initiative in the US. And so we collaborate with many of these programs and many other researchers that focus on a particular cancer, as an example. And but at the moment we're world first in terms of making precision medicine available to every child.
Oh, excellent. That's certainly a pioneering field that you're leading. And so I guess there'll be a lot of data that needs to be exchanged. And I think different countries may have different approaches to how they see privacy. Have you encountered any sort of problems in that sort of space?
Yeah, and in fact, across the jurisdictions of our own state and territories in Australia, that can be a little bit problematic, particularly in the germline space when we're talking about cancer predisposition and setting up a national registry for that. That's been a challenge. Europe probably has the most strict privacy laws through GDPR. And we endeavour to meet or exceed the most stringent guidelines or standards around the world. Yeah. But we do share our data, and we've got a process for that, which I'm happy to talk about.
Oh, that's really interesting. So just bringing it back to the idea of what it means for the patient, is it mainly in the space of stratifying the risk further with this information that you now have had? And does it potentially mean that we can have new treatments or targeted or more personalized therapy for the children?
It can be both of those.
Oh, okay. Yep.
It can be try and better understand what the cancer is and how it's behaving, and also potentially how it might behave in the future, so prognostic information. And it's, in a sense, it's really redefining how you can diagnose down to a much more stratified level, eventually to the individual.
Yeah.
And then the treatment is absolutely one of the things that we focus on. We want to be able to match, the molecular features or particular genetic targets to novel treatments that are available. We want to be able to identify when children might be good candidates for immunotherapy as well, which is slightly different. And immunotherapy hasn't had a huge amount of success, had some early success, but it's proven more challenging in children because we, first of all, didn't understand the immune landscape in children with cancer, in childhood cancers.
Yep.
And we've done a lot of work to do that and published on that, which has been, filled a really big gap in our knowledge for it. And then now that means that we can start to actually identify cancers that may well be a better option or better target for immunotherapy. So there are lots of different options there, and of course there are lots of new kinds of treatments coming in. Talking about RNA vaccines is all the rage right now. And how can we use the precision medicine and the data and the results, the information that we get out of that, to inform better matches to treatment.
And I guess that sort of comes into one of the topics that I had was, well, we're moving, your work has moved from research and is slowly being translated into the healthcare setting. And that comes with that sort of a unique set of challenges. And I guess, I don't know what the regulations are around precision medicine. Are there any at all in place at the moment?
So in terms of regulation, obviously in Australia we've got the NPAT guidelines and we've got the NADA accreditation process that laboratories have to go through. Zero itself is still a research program in a research environment.
Right.
However, I come out of a NADA environment.
Yes.
And so everything that we've set up has been set up with a view to, even though we're not accredited, it's been set up with a view to act as though we were. And the reason for that is because our results do go back to treating clinicians.
Yes.
And those oncologists do use that information to make treatment decisions or patient management decisions. Those decisions are at the discretion of the oncologist.
Sure.
We just provide the information in a clinical research report. We also have a national multidisciplinary tumour board that everyone dials into around the country once a week. And that's for the most complex cases. And the treating clinician, the oncologist, will dial into that meeting as well. So you can discuss their patient in real time and really understand. It's a knowledge platform, it's a learning platform, but it's also helping to make actual treatment decisions real time. So while we're in the research environment, we have far more stringent practices than your average research program. And I'm certainly not trying to denigrate what researchers do. Absolutely not. I work at a research institute, but we do have more stringent standards to work by. Now, what needs to happen to implement precision medicine or any other kind of research-led care is to try and find a bridge between pure research and the clinical care.
Yes.
And right now we sit on that bridge. We have created the bridge, but we need to find a pathway through. And that means working with the department. It means working with advocacy groups. It means working with the professional membership societies for us to be able to find that pathway through so that others can follow, because there is nothing for it. There is nothing. There's a very big gap between research and clinic now. And we're working on creating that bridge.
Oh, that's really interesting to hear. And I guess with any sort of innovative work, and especially when you're talking about sort of lots of data here, that interface between clinicians and yourself generating that data is important. Do you find that the clinicians are readily approachable and kind of understand the limitations around the work that you do?
Yeah, so when we first started out, of course, we had to get some runs on the board, and it's always about doing, demonstrating that you can do something and building confidence and trust. Yeah. And it took a little bit of time to do that. But now what we see is that the clinicians, there is demand for what we do. So there are about 150, 160 Hannah's kids a year in Australia. Almost every one of those will end up on zero. Of the 1,000-odd children who are diagnosed each year, we're currently enrolling about 70 children a month. So that's probably close to 850 a year. Just last week, we had 18 children enrolled on the program. So that shows you the level of demand for this kind of testing platform, precision medicine testing platform. So I think, we got those early runs on the board, we built confidence and trust, and we have this seamless, we created this together.
Yep.
Right? And we really have created it together. The clinicians, the researchers, clinicians, scientists, and allied health professionals all working together to deliver something that works for all of us. We've got quite a strong psychosocial impact study, which is really looking at the psychosocial impact of the use of precision medicine in the care of the child.
Yeah.
Now that study is looking at the child experience, the family experience, the research scientists, the clinicians, the allied health professionals. So, genetic counsellors.
Looking at all the stakeholders.
So it's looking at the whole picture, if you like, whole of system, whole of picture.
Yes.
And we use that, it's very important research, but at the same time, it's also informed what needs to change about the program. So we can make iterative improvements over time because we've got that feedback.
Yeah, that's very interesting to hear. So in the field of precision medicine, where would we see ourselves in 10 or 20 years?
I would like to say that there will be zero children dying of cancer or zero anybody dying of cancer. I don't think that will happen in my lifetime, but I would like to think that in the next generation's lifetime that perhaps we will get closer. In 10 years, I very much hope that this model of care will be embedded in health systems, that the health system will have been adapted to the model of care rather than the model of care being adapted to the existing health system.
Right. Yes.
Because we have a great health system, but it was designed for medicine 40 years ago.
Yes.
And so we need to try and move closer together. There will be compromises at both ends, but we need to try and move the existing health system and to adapt to the new models of care, because they're very different. And I think they will be revolutionising, and, it's a huge paradigm shift for how we do this. 20 years, this should be just a no-brainer, and it should be point of care.
Just becomes a standard of care.
Point of care.
Excellent.
Yeah.
Thank you very much for your time, and that's all the time that we have, and thank you for listening.
Thank you, Leo. It's been a pleasure.